Good afternoon, everyone. My name is Cynthia Delgado. I'm an associate professor of medicine at the San Francisco VA Medical Center and at UCSF. I am delighted here today to be a moderator for the next session, and I'm equally delighted to introduce my friend and colleague's presentation, Dr. Lilia Cervantes, who is an associate professor in the Department of Medicine at Denver Health Medical Center and the University of Colorado, where she demonstrates an unparalleled commitment to diversity through her patient care, community service, research, and health policy activism. Following her internal medicine residency at the University of Colorado in 2008, Dr. Cervantes went on to obtain her Master's of Science in Clinical Science, became an associate professor of medicine and a hospitalist at Denver Health Medical Center. In addition to her patient-centric roles at the Denver Health, Dr. Cervantes has held a variety of roles in the health equity space. These include founding Denver Health Medical Center's Health Equity Learning Series and the Healthcare Interest Program, a pre-health pipeline program for undergraduate students interested in healthcare careers. Dr. Cervantes attributes her passion to become a physician to her background as a bilingual Latina who grew up in poverty. She says that her upbringing allows her to use this unique lens to connect with her diverse patient population and to advocate for marginalized communities and eliminate structural inequities. Her experience with an undocumented immigrant with kidney failure was the catalyst for further research on marginalized patients without access to healthcare, which earned her interviews with NPR and CNN's chief health correspondent, Dr. Sanjay Gupta. Her research and advocacy led to Colorado Medicaid expanding access to scheduled dialysis for undocumented immigrants with kidney failure. Upon announcement of the change, Dr. Cervantes was recognized as the driving force whose research informed the decision. The title of the talk today is Kidney Disease Disparities Among Latinx, Challenges in Community-Based Interventions, and we are delighted to have Dr. Cervantes.
Hi everyone, thank you for inviting me to present to you today. It is such a pleasure to present on a topic I'm so passionate about. I have nothing to disclose and all the opinions in this presentation are my own. For today's presentation, I'm going to begin by describing Latinx community characteristics, and I'll describe them in the U.S. as well as disparities in Latinx with kidney disease. And then I'll move on to very briefly discuss my research on the undocumented community and how that led to health policy change here in the state of Colorado. And I'll spend most of my time describing some of my own work in the documented Latinx community with kidney disease and how we're using culturally tailored interventions to address some of these disparities. The Latinx community in the country represents about 19% of the U.S. population, or about 62 million. The 2020 census results show us that in the past 10 years, the Latino community has grown about 23%, while the non-Latinx community has grown about 4%. Those states with the largest Latinx communities, as you all know, are California, followed by Texas and Florida. The majority are from Mexico, followed by Puerto Rico, and then Cuba and El Salvador. The Latinx community is heterogeneous with respect to immigration status, immigration generation, country, language, and race. With respect to race, for example, a third self-identify as white, a fifth as black, and a quarter as some other race. And with respect to language, about 2/3 of the Latinx community report speaking English proficiently, and a third report limited English proficiency. And with respect to immigration status, it's estimated that of the 62 million Latinx in the country, about 20%, or 12 million, are undocumented. The Latinx community faces a disproportionate burden of social challenges. Unemployment rates, for example, average about 12% compared to around 8% for non-Latinx communities. The poverty rate has decreased among Latinx from 18 to 16%, but is still greater than non-Latinx whites at about 7%. With respect to education, we've seen an improvement in the Latinx community, so there are more Latinx that are enrolling into four-year colleges. However, they still lag behind non-Latinx whites in college completion rates. And with respect to health insurance, the Latinx are the highest racial ethnic group to be uninsured. The Census Bureau reported in 2017 that nearly 18% of the Latinx population was not covered by health insurance compared to 6% of non-Latinx whites. And among undocumented, that proportion is even greater. 33% of undocumented children in 2018, and 45% of those who are non-elderly adults do not have health insurance. Separate from the regular social determinants of health that we're all familiar with, the Latinx community also faces unique challenges. An estimated 66% of Latinx patients with kidney disease report limited English proficiency, and there's no data or little data available on the availability of language and culturally concordant educational materials in the nephrology setting or in the dialysis center setting. One final and very important social challenge is that because of immigration status, many have no benefits. Undocumented immigrants, for example, do not have access to Medicare, most state Medicaid programs, and are excluded from the provisions of the Affordable Care Act. And so this means that preventive care becomes especially difficult for the undocumented Latinx community. The prevalence of kidney disease among Latinx individuals is similar to non-Latinx individuals, but varies greatly across Latinx groups. In the Hispanic Community Health Study, which assessed a population-based cohort of over 16,000 Latinx between 2008 and 2011, the age-adjusted prevalence of kidney disease was 14% overall, and ranged from 7% for Latina women with a South American background to 17% for Latina women with a Puerto Rican background. Among Mexican Americans, the prevalence of kidney disease has nearly doubled. This figure is from a recent study published in JAMA that looked at socioeconomic status and serum creatinine levels using NHANES data for the years 1988 through 2016. And they found that the trend in kidney disease prevalence in non-Latinx whites and non-Latinx Black persons had remained stable since 2003, but in Mexican Americans, which is that blue line that you see in this figure, the prevalence of kidney disease had nearly doubled, and this is between the years 2003 to 2015. The USRDS also assessed kidney disease prevalence in subgroups of U.S. adults, and they looked at adults by insurance, income, education level, and also using the NHANES data. With respect to health insurance, they found a decline in kidney disease prevalence among those covered by Medicare and Medicaid, but an increase in kidney disease prevalence for those without health insurance. And the difference is 11% versus about 9%. The prevalence of kidney disease was also higher among individuals with lower income at about 18% for those below the poverty line versus 14% for those above the poverty line, and also higher among those with a lower level education, so about 17% for those with a less than high school education versus 13% for those with some college. Diabetes, as many of you know, is the primary etiology of kidney disease and kidney failure among Latinx groups. It currently affects about 20% of Latinx and is expected to affect over 50% of Latinx in their lifetime. Diabetes and kidney disease and its progression to kidney failure can be prevented through better glycemic control and medications that slow the progression. But among Latinx, there remains poor glycemic control, especially in our state in Colorado, and there's low use of those medications that reduce the progression. Unfortunately, most Latinx who have kidney disease are also unaware that they have kidney disease. In the Hispanic Community Health Study, only 18% of Latinx individuals with kidney disease were aware that they had it. With respect to end-stage kidney disease disparities, the absolute difference in incident end-stage kidney disease rates between Latinx and non-Latinx whites has declined over the last few years, but remains nearly 30% higher in Latinx. Latinx are less likely to receive pre-dialysis nephrology care. This table that you see here is from a recent study in JAMA that used USRDS data to assess national trends in pre-dialysis nephrology care 1 year before dialysis initiation, and they looked at the years 2005 through 2015 and found that Latinx patients were the least likely to receive pre-dialysis nephrology care with an odds ratio of 0.6. We also know from the USRDS yearly report that Latinx are more likely to have crash dialysis starts and initiate dialysis with a catheter over an AV fistula, and they're less likely to have had a preemptive kidney transplant as well. And with respect to palliative care, Latinx are more likely than non-Latinx whites to have an invasive procedure and to be hospitalized during their last 6 months of life. I want to pivot now and describe some of my research in the undocumented dialysis community, but I think many of you have heard about some of my work in the undocumented, and so I'll keep this fairly brief. The woman that you see in blue here is Hilda. She was my patient and friend and inspired me to pursue research in kidney disease. She was an undocumented immigrant and mother of 2 elementary school-aged boys with kidney failure. And because she was undocumented, she could only be dialyzed once every 6 to 7 days. And so once a week, basically. She had to wait until she was critically ill to be dialyzed. And the weekly psychosocial distress this caused her boys was too much for her. On a weekly basis, her boys didn't know if she would survive to the following week. And so she made the very difficult decision as a mother to give her boys up for adoption. And so together we interviewed several families until she found the right one. And after they went through the foster to adopt process, Hilda withdrew from dialysis and passed away. She passed away on Mother's Day in 2014, and so it's because of her that I began this research, and because of her that I continue to focus on research that will create change and eliminate structural racism. Across the country, some states provide standard dialysis to undocumented immigrants, and so back in 2019, I reached out to all 50 states to try to get a better sense of which states provide standard of care dialysis versus which don't. Those states that you see in green are where undocumented immigrants can be dialyzed 3 times a week and care is reimbursed by Medicaid. The states in red are where undocumented immigrants in 2019 had to rely on emergency dialysis. And those states in orange are where there's sort of variation. So within that state, some cities might provide standard dialysis and some might not, or they receive standard dialysis but care is not reimbursed through Medicaid. And so for the undocumented community, my research, my first project focused on describing their experiences from their perspective because I really wanted to give them a voice. And so in this first study that I published, I interviewed 20 undocumented immigrants face-to-face in Spanish and asked them to describe their experiences as they rely on this type of care. And patients described a significant symptom burden and psychosocial distress because they could only receive dialysis every 7 days, and so they were basically waiting for their symptoms to accumulate to trigger that emergency department visit. They also described death anxiety because on a week-to-week basis they weren't sure if they would survive to the following week. And they also described risking death to meet admission criteria, meaning that they would consume foods high in potassium just outside our hospital doors so that they could be dialyzed. One patient said, "You can't explain your illness. You arrive in bad shape. You need to have a high potassium or they send you home. Sometimes you crawl out when they decide to not do dialysis. You eat a banana because it's high in potassium even though you may die, and you go back and hope that they will do dialysis." I also conducted semi-structured qualitative interviews with 50 interdisciplinary clinicians and asked them about their perspectives in providing this type of care. I interviewed 25 in Colorado and 25 in Houston, Texas, and they described significant drivers of burnout, including emotional exhaustion from witnessing needless suffering and high mortality. They reported feeling like they were jeopardizing their patients' trust because sometimes they had to turn patients that were visibly ill away from the ED, and they couldn't offer them admission for dialysis because they weren't sick enough. And many of them described detaching from their patients so that they wouldn't feel too much empathy. Both of these studies, the one where I interviewed patients and clinicians, were critically important because they probably garnered the most media attention across the country and helped me begin to build a coalition of stakeholders interested in changing access to care in our state. And then to inform additional research projects, I also connected with opponents and key decision makers and health policy stakeholders because I wanted to learn from their perspectives what research gaps there were, what would change their minds. And so a question I consistently got was, how does this impact mortality and quality of life and utilization? And so to answer that question, we conducted a retrospective cohort analysis comparing looking at mortality differences and utilization between undocumented immigrants who receive emergency dialysis in Colorado and Houston, Texas. And we compared them to undocumented immigrants receiving standard dialysis in San Francisco. And we found that mortality is 14-fold worse 5 years after initiating dialysis, and inpatient utilization was 10-fold worse among those who rely on emergency dialysis. And I just want to point out this picture is of two of our most important stakeholders here in the state. One is Tracy Johnson. She is our state Medicaid director in red, and the other is Peg Burnett in gray. She was our chief financial officer. After additional stakeholder engagement, and once we understood sort of the policy path and steps that we needed to take to change access to care in Colorado, we received notice from our state Medicaid agency in August of 2018 that they were going to include the diagnosis of end-stage kidney disease as a qualifying condition for emergency Medicaid. And this sub-regulatory language change basically expanded access to care for this community. And so this is a picture of some of our patients alongside our stakeholders celebrating at my house. And at this point, the patients had created a group called Club Riñones Latinos, and they're wearing the shirts that they made for their club. And then lastly, to inform those states that are interested in also making a similar health policy change, we conducted this pre-post intervention study. We basically assessed quality of life, symptom burden, and also conducted qualitative interviews before and after patients transitioned from emergency to standard dialysis. We found that there was statistical improvement in all 5 quality of life subscales, and there was improvement in 7 out of 11 symptoms. And in conducting these interviews, we learned before patients transitioned to standard dialysis that they were anxious that their bodies might not handle 3 times per week dialysis well, because they were used to dialysis once a week. And they were also anxious of facing discrimination at these outpatient dialysis centers. And then after transition, we learned from patients that they had experienced extreme relief in receiving consistent care and no longer felt deprioritized, and that feeling of death anxiety had subsided. And so in an effort to sort of change this across the country, the National Kidney Foundation has put this letter together addressed to state Medicaid directors to basically advocating for a similar health policy change. And we now have several signatories on this letter, including the American Society of Nephrology, the RPA, the Society of Hospital Medicine, SGIM, several others. And so we're hoping to change this on a state-by-state basis across the country. And so alongside my research on the undocumented community, I also conducted research on our U.S. citizen Latinx community with kidney disease. And my first research focused on improving the well-being of this community. I started this body of work with a mixed method study focused on understanding the palliative care preferences and needs in this community. And so this first study was sort of an observational cohort study. I used an end-of-life care survey that had been previously used in dialysis patients in Canada. And so I basically took this survey, translated it to Spanish, and modified it to our Latino community. And I surveyed about 60 Latinos from 3 separate inner-city dialysis centers. And I just want to briefly describe my results. I found that most patients want to have a discussion about goals of care, would prefer to have this conversation with their nephrology team over their primary care doctor, and they want to have this on a routine or yearly basis, meaning they don't want to wait until they're in their last months or days to have this conversation. They want to have it preemptively. And they also want to have this type of conversation at home so that family can be around. Patients also said that if they had 10 days to live, they would prefer to spend those last 10 days at home, yet very few patients had had this conversation with their family or had completed any kind of advance directive. For this community, Family is important, and the majority reported that they rely on family for social and emotional support, and they prefer family to make medical care decisions. With respect to symptom burden, I asked patients if they would be open to pharmacologic symptom alleviation, and all patients said absolutely they would be open to taking pills to reduce their symptom burdens like pain or nausea or other things. And then lastly, I asked patients whose choice it had been to initiate dialysis. And their options were their doctor's choice, personal choice, or family choice. And interestingly, over 50% of patients said that it had been their doctor's decision to initiate hemodialysis. To better understand some of these palliative care preferences, I ended up conducting qualitative interviews with 20 of the 60 patients that I had first surveyed. And these questions were sort of open-ended, and I asked them to describe sort of their experience with palliative care discussions and preferences as well. We identified 4 themes, but I'm going to briefly just describe 2 or 3 of these themes. In our first theme, I asked patients about pharmacologic symptom alleviation, and what was interesting is that all 20 patients that I interviewed stated that they would not want additional pills or medications to alleviate them of symptoms. They said that they preferred to distract themselves or use traditional remedies. And interestingly, some patients described fatalism, which was the sense that one deserves to have symptoms for something they did in the past. They also described those things that improve well-being, such as family and friends as support and faith. Many patients reported that other patients or their peers were strong sources of support, and many wished that such peer relationships could be formalized in the dialysis center setting. They also described wanting a better understanding of their illness, so more information and education so that they could be more engaged in their own care. And then lastly, participants described those aspects that were most distressing about their illness. Many patients said that the most distressing aspect of their illness was not being able to eat their traditional foods because it impacted their cultural identity and because they felt like the restriction decreased their ability to socialize with family. Many of our participants also described challenges with social factors, so frustration with transportation because it didn't pick them up or came late, frustration with finances because they couldn't afford protein and they were told they had a low albumin, or they couldn't afford their medications or clinic visits. They also described difficulty with communicating with their clinicians because oftentimes interpreters were not available. And so one patient said, I think that talking to others with kidney failure helps. I've been doing dialysis for over 3 years now. People come to me because they don't know. They have concerns. I think that talking to other kidney failure patients will be a good idea. In conducting these first 2 studies and being present in the dialysis center, often connecting with these patients, I learned 2 super important lessons. The first is that this community needs to be activated or more engaged in their care. There is a clear power dynamic, and I was surprised in asking patients that many of them had said that it was their clinician's choice to initiate hemodialysis rather their own personal choice. And so this helped me realize that any kind of community-based intervention would need to include a component of patient activation so that they can be more engaged in their own care. The second important lesson I learned is that qualitative research is particularly helpful in understanding some of the challenges faced by this community. When I asked patients during that initial survey about their acceptance of pharmacologic symptom alleviation, all of the patients had said that they would be open to pharmacologic symptom alleviation, but then I interviewed 20 of those same 60 patients and they all said that they would not be open to pharmacologic symptom alleviation. And so my experience with this community is that there's a power dynamic, and when we survey patients, they tend to respond in a way that they think we want them to answer. And so with qualitative interviews, what's incredible is that you can spend the first 5 to 10 minutes building trust and rapport with the patient, and this allows us to get closer to the truth. And so I like to use qualitative research for that reason. Step 2 in all of this work was to gather a community advisory panel that would inform the intervention. And so I brought together a group of patients, caregivers, interdisciplinary clinicians, because I wanted whatever intervention we developed to be meaningful and effective for this community. And so we met every 2 weeks or so for 3 months, and I audio recorded the meetings, conducted a thematic analysis, and sort of presented an update from our last meetings at each meeting. And patients shared their stories, and we discussed several types of community-based interventions and decided to create a peer navigator intervention. Some of you might be familiar with navigator interventions. They're also called, navigators are also called promotoras or lay or community health workers. Promotoras or navigators, they tend to be lay non-medical individuals who are culturally concordant with the community. So maybe they have a shared experience or ideas or values or the same illness experience. And they also tend to be language concordant. The Navigator program was first developed in 1989 after the American Cancer Society highlighted poverty as a key factor that contributed to worse cancer outcomes, especially breast cancer outcomes in the Black community. To address this concern, the American Cancer Society supported the first ever Navigator program, and it was led by Dr. Freeman in Harlem, New York. And in this first Navigator program, Dr. Freeman hired culture and language concordant navigators who identified critical barriers to care, including medical barriers like inability to obtain medications because people live in pharmacy deserts, or social barriers like issues with transportation, childcare, or taking the day off from work. And these Navigator programs grew and eventually eliminated disparities in 5-year survival for breast cancer. And so I wrote a perspective narrative that describes Navigator programs in kidney disease and their potential to improve patient-centered and clinical outcomes. I'm very motivated to see if patient navigator programs can improve person-centered and clinical outcomes for kidney disease patients, and for various reasons. One, we know that racial and ethnic minority groups are sort of disproportionately burdened by kidney disease and social challenges, and some of these social challenges are remediable and can be addressed by navigators. Second, we don't have a diverse healthcare workforce, and there's often a need for language interpreters. And so as we work to diversify our healthcare workforce, navigator programs can serve as a bridge to healthcare providers. And then third, navigators have access to providing care and connecting with patients at home. And so they can provide emotional support and education to caregivers. And lastly, navigators can be trained in patient activation and motivational interviewing, and so they can really work with patients to be more engaged in their own care. And so I designed a one-arm prospective peer navigator study and assessed the feasibility and acceptability. This intervention was designed to provide 5 visits from the navigator, either in the dialysis center or at home. And the focus of these 5 visits were on social support, including advanced care planning, care coordination, and diet, and then separately also mental health support. For advanced care planning, the navigator basically introduced the topic of advanced care planning and facilitated some of these conversations with family. She also provided support with completion of advanced directives. And then to support care coordination, the navigator connected with patients and asked them about those social challenges that were most pressing, that were making it difficult for them to take care of themselves. And then she worked with them to remediate those social challenges. To support diet education, the navigator met with the patient and the registered dietitian at the same time and provided language interpretation and helped the registered dietitian sort of culturally tailored the information that they were receiving about diet restriction. And then lastly, the navigator used the PHQ-9 and the GAD-7 to assess for depression and anxiety and connected patients to care. We enrolled a total of 40 patients. The majority were Spanish speaking, lived below the poverty line, had a low level education, and diabetes. to assess the feasibility of this type of study, we looked at recruitment, retention, intervention implementation, and intervention delivery. So sort of the number of visits, the length of these visits. And in total, we approached a total of 49 patients, and only 9 patients declined to be in the study. So we had a recruitment rate of about 82%. None of our patients withdrew from the study, and in fact, we were able to collect data on everyone except for one patient who passed away on hospice. And patients received a total of 5 visits, and each visit was an average of an hour and a half. To assess acceptability, I used a modified patient navigator assessment tool and found that the majority of patients felt that the navigator had improved their quality of life, provided emotional support, helped them make important decisions for themselves. And with respect to patient activation, patients stated that that because of the intervention, they were more engaged. They tried to better understand their illness and ask questions and be involved in decision making. And to further assess acceptability, I also conducted semi-structured qualitative interviews with 9 dialysis center staff and our navigator, and learned that the dialysis center staff felt like the 40 patients that had been part of the study were more interested in transplant, and some had gone on to begin the evaluation process for transplant. And they also felt that patients had started attending their dialysis sessions and missing dialysis sessions less. And so one individual said the patient navigator went to some patient's home and actually went with them to buy groceries and stuff. We also had a patient struggling with alcohol, and the navigator advocated for him to receive help and treatment. Another individual said, she spoke Spanish and knew their culture. I don't understand the different foods and the different ways the family interacts at home. She can tell us what types of food are in the cupboards and what the kitchen looks like, or if someone can help them prepare meals. Step 3 in all of this work was to engage yet additional stakeholders. And so I focused on understanding the perspectives of interdisciplinary clinicians to further shape this peer navigator intervention before conducting the larger RCT. And so I conducted qualitative interviews with interdisciplinary clinicians and asked them about their perspectives on how social challenges faced by Latinx individuals affect their care. As many of you know, clinicians are often inadequately equipped to address the social challenges faced by patients, but have insight on the barriers and facilitators to kidney care. And so I interviewed a total of 30 interdisciplinary clinicians who worked for 2 large dialysis organizations and 2 small not-for-profit dialysis organizations. The clinicians included social workers, registered dietitians, medical directors, nurses, physician assistants, and dialysis technicians. I met with them in private and conducted these face-to-face interviews and then conducted a thematic analysis. I'm really excited about these findings because they have very important implications about needed changes in the dialysis center setting. And so I want to just briefly describe the themes from these interviews. One of our themes centered on compromised quality of care. Clinicians described communication challenges, including difficulty with telephone interpretation because those conversations are not personalized. Patients oftentimes could not hear the phone and expressed how using the phone was time-consuming. Clinicians also described how oftentimes other clinicians skipped rounding on patients who didn't speak English because they didn't have time to use a phone interpreter. Many described preferring in-person language interpretation because it feels like it's a more personalized approach, but they are told that it's cost prohibitive and in fact sometimes unable to even request one, even for an end-of-life conversation. And so as a result, many of the Spanish-speaking staff, especially those with technical roles like dialysis techs, reported being asked to step into the role of interpreter, and because of power dynamics, feeling compelled to provide language interpretation. And so many of them felt like they were balancing providing language interpretation with their dialysis tech duties. And then clinicians, especially those that were dietitians and social workers, described a lack of language and culturally concordant educational materials to provide diet education or in some of those measures that are used in the dialysis center setting. And so one clinician said, my dialysis company would not be happy if I requested an in-person interpreter because it's expensive. And another participant said, I've seen dialysis techs cry. They're told, I need you to interpret for me right now, and the techs have to drop everything they're doing. Our second theme centered around difficulty with healthcare access, and clinicians here described how their patients struggled with self-care because of unreliable transportation that oftentimes was late or just didn't pick up the patient at all. Many face economic instability that limit a patient's ability to adhere to medications or clinic appointments or to keep a strict diet. And many of our social workers described how patients' benefits are sometimes dropped because of late paperwork, like Medicare or Medicaid. The third theme centered around psychosocial well-being, and clinicians here described how many without family or caregivers struggled with isolation, and they observed patients who were hopeless or depressed be less engaged in their own care. They also reported hearing from patients that they faced stigma due to the burden of pills and the diet restriction that often meant they had to eat something different from their families. And lastly, clinicians noted how oftentimes patients miss dialysis because of the myriad of social challenges they had to prioritize over self-care. The last theme centered around ways to improve care for the Latinx community. Here, clinicians described how awareness and understanding of the influence of culture on attitudes, beliefs, and experiences could foster some of those cross-cultural communications and also improve care. They described person-centered care that activates patients so that they can be involved and engaged in their own care. And clinicians also described the need to support primary caregivers because they're the main source of a patient's emotional support and decision-making. And lastly, clinicians also brought up this idea of having peers like peers who have an experience with kidney failure to provide some support emotionally and with navigating kidney replacement therapy. And so one clinician said, everyone that is poor has transportation issues. It's always been an issue, 90% of the time. My patients are late because transportation was late or didn't pick them up. I feel so bad. Many of us can't relate, but someone who comes from their community would have an easier time connecting and could talk to them about kidney transplant and maybe have more of an impact than the rest of us. And so this additional qualitative study and the 1-hour peer navigator intervention informed the RC team that we launched several months ago, actually 1 year ago now. I slightly modified the domains from that first initial navigator intervention that I described earlier. And so our current peer navigator intervention focuses more heavily on providing support with social challenges, and then second, communication, and third, patient-identified goals of care and adherence. And so to support social challenges, the navigator meets with patients, gains their trust, and asks them about that social challenge that is making it difficult for them to take care of themselves, and addresses that social challenge during the subsequent visits with the patient. To support communication, the navigator provides language interpretation when the clinician rounds with the patient or when the registered dietitian meets with the patient. And to support patient-identified goals of care and adherence, the navigator develops a trusting relationship and then uses her skill set in motivational interviewing and patient activation to better understand the adherence goals from the patient's perspective. So this is, very patient-centered, so that it's not shaming patients for missing dialysis or shortening it or not following their renal restricted diet. It's really, adherence from a patient's perspective. And our primary outcome is a composite measure of patient-identified goals of adherence, and secondary outcomes include social challenges, satisfaction, quality of life, adherence, mortality, as well as hospitalization. And so in this study, patients are randomized to receive either 7 visits from the patient navigator and additional visits if the patient requests them, or standard of care. These are our 2 patient navigators. Carla is the one in pink, and she just recently received her kidney about 2 months ago now. And Claudia is the one in gray, and she has personal experience with kidney failure, providing care to her family members. And so we've enrolled a total of about 88 patients. Our goal is about 130. And to give you a sense of some of the social challenges that our patients are facing, I pulled our data on social challenges for this presentation. Over half of our patients use public transportation, and when asked about transportation issues, the majority said it has kept them from getting to dialysis, and a third reported trouble getting to a medical appointment or picking up medications. When asked about housing, a third of our patients were worried about losing their home. And with respect to food insecurities in the past year, half of our patients said that it was sometimes or often true that they worried food would run out before they got money to buy more. A third said that it was sometimes or often true that the food they bought didn't last and they didn't have money to get more. And then half of our patients said it was sometimes or often true that they couldn't afford to eat balanced meals. Also, to get a sense of the patient's experience with this intervention and to further shape the intervention, because I want to make sure that it's acceptable, I connected with patients who had completed the intervention and asked them about their experiences with the navigator. And I captured a few quotes that I want to read off to you. The first one, a patient said, "My ankles were always swollen. I was always uncomfortable. I drank too much, ate too much salt. I didn't understand. The dietitian doesn't speak Spanish, and so I didn't understand. I had been there for years, and no one ever explained any of this. Claudia came, and now I understand. Now I'm comfortable. Now I know how to take care of myself." Another patient said, "Claudia talked about transplant. She said that life would be like it was before. No more dialysis. No one explained what the process to be listed looked like or what I would feel like afterwards. Claudia explained all of this, and she even came with me to my first transplant appointment." And so what I want to say is that my experience with this intervention has been such that the Latino community seems to be more engaged and active in their own care because they now have the information or education that they needed to know how to better take care of themselves. And what I've also learned is that there's a high degree of health numeracy illiteracy. And so, when patients hear you can only drink 1 or 2 liters a day, or you have to have this many cups of protein, or whatnot, what our navigator has done is provided patients with measuring cups, and she's also connected with them in their home to sort of go through their cupboards and better understand why it is that they have too much salt in their food. A lot of our patients use chicken bouillon in food, and they didn't think that that was high in salt. We had another patient that was eating high amounts of tuna, which is a cactus fruit, and it tends to be really high in potassium. And so it wasn't until Claudia sort of looked through their cupboards at home that she realized, that there were these other foods that patients maybe weren't being asked about because they're particular to their culture, and we're making it difficult for them to adhere to their renal diet. And Claudia provides each of our patients with a Nalgene bottle and goes through the measurements with them and helps them understand, if you eat soup, then you'll be this high on your Nalgene bottle, and then your coffee makes it this much higher. And so she really helps them visualize it and understand it using a Nalgene bottle and measuring cups. And so that's been a lot of fun. And when I've connected informally with our social workers, they've all just been so grateful because, these are inner city dialysis centers where all the patients are facing social challenges. There's a lot of patients who experience homelessness and are being evicted from their homes. And so these social workers really appreciate this partnered approach to helping patients be more activated, but, also feel like they are experiencing an improved quality of life and better well-being because they understand why they're getting dialyzed and why they're having to take medications and whatnot. And so Lastly, I just want to very briefly describe this newer community health worker program that we launched in the state of Colorado to reduce the burden of kidney disease among Latinx with diabetes. We partnered with one of our Latinx community-based organizations called Vuela for Health because they have several navigators who are trusted in the community, and they were already delivering educational nutrition and fitness and diabetes. They were hearing from the Latino community who wanted to be more informed about kidney disease, and so it was a perfect partnership. This picture includes our group of 5. And our 3 aims are basically to create language and culturally concordant kidney disease education, improve awareness of kidney disease through education and screening, and lastly, to reduce the progression of kidney disease to kidney failure by connecting patients to clinical care. And so we are in the process of developing a kidney disease module that is language and culturally concordant. And we're using materials from the National Kidney Foundation as well as online materials to make sure that we are culturally tailoring this to the community. And we plan to connect with our community health workers and our patients to further modify this. We're also partnering with the National Kidney Foundation to screen patients in community settings and also to screen those patients that come to our partner organization for education on diabetes. And then lastly, we're connecting with all of our FQHCs here in the state to make sure that patients who do screen positive for kidney disease can receive clinical care. And so as I continue this research, what's important is to continue research that sort of answers health policy gaps and continues to move the needle towards health equity by addressing structural racism and structural inequities. And so with respect to access to care for the undocumented communities, I'm working with UNOS to conduct research that demonstrates inequities in access to transplant for undocumented groups, and we hope to build the case that will eventually lead to benefits for transplant for undocumented immigrants. In the state of Colorado, we've also passed several laws that will help us improve access to care for our community. With respect to community health workers, my plan is to do a cost effectiveness analysis and work with our patient and partner stakeholders to build the case that this is, that community health worker programs need to be reimbursed by CMS because we are reducing the prevalence of kidney disease and improving the quality of life and patient-centered outcomes among those on dialysis. And then lastly, like many of you have been focused on the COVID-19 pandemic, and so we've conducted a few studies focused on our Latino community to understand the challenges that they have faced. In the state of Colorado, undocumented immigrants had no access to outpatient COVID-19 care, but we were able to work with our patient and partner stakeholders and make the case that state Medicaid needed to expand access to outpatient COVID-19 care for our undocumented immigrants, and they were able to make the same change as they had done with end-stage kidney disease. And so to end, I want to thank my my research community, including my mentees and my patient navigators. The picture on the bottom left is of Hilda's sons. We just celebrated her oldest son's graduation from high school, and he's off to college now. And then I also want to thank my family. Please feel free to reach out with any questions. I'm on Twitter and I'm pretty active, but I'm also putting my email out here in case any of you have any questions or want to collaborate or connect on research. Thank you so much for inviting me, and I look forward to connecting with you in the future.
What an incredible body of work. Unfortunately, Dr. Cervant was unable to be with us live, and we are unfortunately also out of time. This was a comprehensive examination of the challenges faced by individuals from heterogeneous Latinx communities. The presented solutions and approach to address access was a true patient-centered grassroots approach. We thank Dr. Cervantes for being a real tour de force and leading the discussion for a change. And the excellent questions that were raised during her presentation will be forwarded to her. On behalf of the National Kidney Foundation, thank you so much for participating.